prompt recognition and management due to the potential for rapid deteriorations and complications in small children. Especially, we see cases in the emergency department and casualty coming with respiratory distress and going to respiratory failure in a very short time. So each one of you should be an expert in recognition, at least of respiratory distress, airway management, oxygenation, and medications. Today we have an expert in this field with us to enlighten us on this topic, Dr. Bindusha. Welcome you, madam, onto this Zoom meeting. I welcome our leader and state president who had been a backbone of this TIPS program, and my dear friend and the vibrant secretary of IAP Kerala, Dr. Gobi Mohan, who have been a constant support for this TIPS program to this program. Welcome you, sirs. I welcome our past president of IAP Kerala, Dr. Jayaraman sir, who has joined us today on this platform. Welcome you, sir. I welcome all the seniors who have been present here today on this platform, and my constant support in this for conducting this TIPS program, my convener, Dr. Nisha, and all other house surgeons who have joined us today for this most important topic in pediatric emergencies in children, in respiratory emergencies, which forms the majority of cases who present in the casualties and emergency department visits. So thank you. Over to you, Nisha.
Thank you, sir. Now I invite Riya sir for the presidential address.
Thank you, Dr. Nisha. I'm keeping the video off as my network is not very good. The leaders of this particular project, Dr. Joni and Dr. Nisha, are doing great work for some time now. And we are having very good attendance also every time. And this day's topic is very, very important. I should say that the knowledge and skill regarding the respiratory emergencies of the house surgeon is the a most important thing, which is going to decide the survival, quality survival of the child. Because most of the time, the first person to see such children will be the house surgeon. And in pediatrics, the most important emergency is always respiratory emergency. So I think Bindusha will teach you how do you identify the sickest of the kids and what to do first, which oxygen device to choose, and all those things. So I wish all the best for the program. I specifically thank Jayaraman sir, Dr. Gopi, and all the seniors who have joined and for their time for their support for this program. And I wish Dr. Joni and Dr. Nisha will continue this great work and enlighten our house surgeons. All the best, Dr. Bindusha. Thank you.
Thank you, sir. Now we will be proceeding towards. So,
a couple of words from the state secretary, Dr. Gopi.
Gopi, sir.
Honorable President Dr. Riaz, Chairperson Johnny, Convener Nisha, Jayaraman sir, other seniors, and my dear house surgeons. Let me congratulate Johnny and Nisha. You have been doing a very good job. The topics chosen by you are very apt and are necessary for the house surgeons. Today's topic is dealt by none other than Bindusha madam, who is a very expert. We know how good she is in her subject. As Johnny and Riaz put it, is the house surgeons who are dealing with the issues in the ER first. So they should know how to triage and and they should basic things they should learn, that when the child is sick and how to intervene. I wish this program a success and happy learning. And I'm sure that in future also Johnny and Nisha will continue to bring such good topics and speakers. Thank you. Jai Hind, Jai.
Thank you, Umar. Now I invite Dr. Bindusha madam. Madam is additional hospital to Trivandrum. In addition to pediatric degrees, Madam has a diploma in allergy and asthma. Madam is speaking on the topic respiratory emergencies in children. And everyone knows that Madam is an excellent speaker. So over to Madam.
Thank you, Nisha. And I would like to thank the office bearers of IAP Kerala, Dr. Riyaz, Dr. Gopi, Dr. Vinakutan, and also the organizers of this TIPS program, Dr. Joni and Dr. Nisha. And are my slides visible?
Yes, yes, madam.
Okay. As Dr. Joni and Dr. Riyaz was saying, respiratory emergencies is the most common pediatric emergency. Wherever you're going to work, whether it is in a hospital, office practice, whether you are in a casualty or emergency room or ICU, or wherever you are, the respiratory emergencies are the most common emergencies that you are going to see. And another thing is that most of these emergencies are eminently treatable. You can treat it very well if they are identified early. But at the same time, if you don't identify these emergencies early, it may lead on to issues also. And another problem, important point that we need to consider is that involvement with the other systems may also present as respiratory emergency in some cases. And I think that rather than me just speaking about the respiratory emergencies, I think I would like this to be an interactive session. So I will be asking you some.
Actually, this latch is for. Okay.
I'll be asking you some questions, and I would prefer that you answer it in the chat box so that I will also understand whatever you are understanding from this talk. Okay. So before we go into the respiratory emergencies proper, we will just go through the assessment of a sick child. Why? Because that is how we are going to assess these patients. I'll be just going through a few case scenarios. So I'll be asking you to assess these patients based on these assessment algorithms. Okay. So whenever you are seeing any child, whether it's in your casualty or OP, wherever any sick child is brought to you, first thing that we need to do is an initial assessment. For doing an initial assessment, actually, you need not even touch the patient. This is not otherwise known as a doorway assessment. While the parent is carrying the child into the office room or into your clinic, then you make a first impression. What is your initial assessment of that patient? Is the baby very sick? That is the only thing that you want to understand by this initial assessment. There are three things that you look for in the case of initial assessment. You will look at the appearance of the baby, breathing, and also the color of the baby. For what do you mean by appearance? How is the baby looking? How is the baby interacting? You can see whether the baby is having good tone or if the baby is flabby. And also you can see whether the baby is interacting with the parent or if the baby is having an incessant cry or if at all the baby is crying, is the parent able to console the baby? Then how is the baby looking? Baby is looking around or just remaining passive. And if it is an older child, you can see whether the child is speaking to the parents and all. And in the breathing, the only thing you look at in the initial assessment is whether the child is breathing, whether there is any apnea or gasping or any abnormal sounds which are coming from the throat, or if there is an increase in the work of breathing. That also is something that you can see very well from your chair. Then you also look at the color of the child, whether the baby is pink, cyanide, or pale and purple. By your initial assessment, you will be able to say whether the child is having any life-threatening emergency. That is the only thing that you will be able to find out. If at all a patient is having any life-threatening emergency, then you need to start an intervention at the same time. You don't have to complete all the evaluation before you address the problem. Here, the assessment and the intervention should always go hand in hand whenever you are treating a sick child. Okay. Then after if the child is having any life-threatening emergency, you straight away go for the intervention needed for the patient, and at the same time you do the primary assessment also. In the primary assessment, you will look at the airway, breathing, circulation, disability, and exposure. In the case of respiratory system involvement, majority of the cases will have issues with the airway or breathing, and sometimes there may even be involvement of the other systems like circulation and neurological systems. So in the airway, you will see whether the airways are maintainable or not. And if not maintainable, we'll have to address that. In the breathing, you will see look at the respiratory rate. You can see whether there is an increase in the work of breathing. You can see the SpO2, see whether there are any retractions. You can look at the chest, examine the chest for any added sounds, air entry, all those things will come under breathing. Under circulation, you look at the heart rate, whether the peripheries are warm, how are the pulses, how is the BP, all those things will come under circulation. Under disability, you do a quick neurological examination, look for any focal neurological deficits. You can look at the pupils and GRBS, all those things will be coming under disability. And you will also need to look for any fever, so for any rash, any bites, all those you have to do. And as somebody is speaking, can you please mute it? Okay, thank you. Okay, after the end of your primary assessment, you will reach a physiological classification. So, suppose the patient is having any problem with the respiratory system, patient may either have a respiratory distress or respiratory failure. What do you mean by respiratory distress? Patient has an increase in the work of breathing, so that the child may have tachypnea and retractions. There may also be tachycardia. But at the same time, the patient will be able to maintain oxygenation. Okay. In the case of respiratory failure, patient is not able to maintain oxygenation. There will be associated hypoxia also. Or the patient may have bradypnea or apnea. The child is not breathing and severe retraction. That tells you that the patient is having respiratory failure. The problem is that if the patient is in respiratory failure, the patient can progress to cardiorespiratory arrest at any time. That tells you that the cardiorespiratory arrest is imminent. It can occur within minutes unless you intervene. So that is the important thing that we need to know about the respiratory failure. And these respiratory distress or failure may be due to 3 types of diseases if it is involving the respiratory system. It may be due to upper airway disease. That means there is a problem in your upper part of the airways, like the larynx, then the trachea. If there is an obstruction there, even the epiglottis and all, if there is an obstruction there, that may lead on to respiratory distress and failure. Or lower airway diseases, like in the case of bronchiolitis, asthma, where the lower airways are involved. That can also present in the same manner. Then some of the parenchymal diseases like pneumonia, ARDS, they are parenchymal diseases. So all these things can present as respiratory issues. And certain non-respiratory causes, sometimes issues with the cardiovascular system. Cardiac failure can present you with cough and breathlessness. Then some renal diseases may present acidosis, may be manifest, may be sometimes treated as respiratory distress. Like other systems also can present as respiratory distress. That is something we always have to keep in mind. Okay, now we are going through a few scenarios, and I would like you to assess these children as I have told you, and we will discuss depending upon that. Okay, so this is a 10-month-old baby who was brought to the emergency room. And this baby, on examination, baby is cyanosed, baby is floppy, baby has only occasional respiratory efforts only, occasional gasping respiratory efforts only. And you are also able to hear an abnormal sound from the throat. Baby has a heart rate of 80 per minute and peripheral pulses are not palpable. And mother also gives you a history that the baby was playing with some beads a few minutes before the onset of respiratory distress. And this baby has an acute sudden onset of respiratory distress. Can you please type in what could be the possibilities And what is the physiological status of the patient? I want to know whether this patient is having respiratory distress or respiratory failure or something else. And where is the problem? Is it an upper airway problem, lower airway problem, or a parenchymal problem? And also, what may be the cause of this problem? Okay, very good. A lot of people has actually typing foreign body aspiration. Okay, that is good. And also, I want to know whether the child is having respiratory failure or distress. Okay, this patient is having respiratory failure only. Why? Because the baby is, you can see that this baby has an acute life-threatening event. That is your initial impression, right? Here the baby is cyanose, baby is floppy, and as I said, there is only occasional gasping respiration. That tells us that this baby is having a acute life-threatening problem. It's a life-threatening disease because we can hear this biphasic stridor, suprasternal retractions are there, and also absent air entry, cyanosis. Everything tells us that there is a life-threatening problem. Child is having a respiratory failure due to upper airway obstruction. Here the history is very obvious. This is an acute onset of distress, and also here you can here the mother is giving you a history that the baby was playing with the bead. So we will always think about foreign body only. Sometimes you may not even get a history like that. The problem with diagnosis comes when you don't have a definitive history which suggests that it may be a foreign body aspiration. So whenever a toddler is brought to you with an acute onset of respiratory distress, we need to suspect foreign. Okay. Here you have the typical history, but in an older child, you may even have a history. You may even have this universal choking sign. So what will you do? What will you do for this baby? This child is actually not only in respiratory failure, this child is actually going into cardiorespiratory failure because as you can see, this child has a heart rate of only 80 per minute and peripheral pulses are also not palpable. So this is a respiratory failure which is going into cardiorespiratory arrest. So what will you do for this patient? Will you start bag and mask ventilation or will you do something else? Here, even if you do a bag and mask ventilation, if my computer is getting stuck in between. Okay, so suppose if the airway is completely obstructed with a foreign body, even if you go for a bag and mask ventilation, you will not be able to make any air enter into the chest. So there won't be any chest rise at all in the case of complete airway obstruction. So you will have to remove that obstruction. So how will you remove that obstruction? That is by, this is an infant. So you go for back slaps and chest thrusts. So what do? You will make the patient lie on your arm. You need to support your arm also. The head of the baby should be at a lower level compared to the body. As you see in this picture, you can see that the head is at a lower level than the body, and the mouth is also kept a little bit open, and you are going to slap the back. You will have to slap the back between the two scapulae with sufficient force so as to expel the foreign body. When you are slapping, the direction of your slap should be downward, and also some force should go towards the head, cephalad also. Downward and cephalad direction, you will have to slap for 5 times. And if the foreign body is not expelled, then you will turn the baby to the front and go for chest thrust. So you need to continue this till the foreign body is expelled, or a foreign body is expelled, you will have to continue this. If it is an older child, what will you do? So if the child is able to cough, we will have to encourage him to cough. Coughing is the most effective method of expelling a foreign body rather than our thrust, whether it is a chest thrust or an abdominal thrust. If the child is able to cough, that tells you that some air can enter into the lung. Then only you will be able to cough. Cough is a forceful expiration, right? There if the child is able to cough, you will encourage him to cough out the foreign body. If the baby is unable to cough, you go for abdominal thrust in the case of an older child. Okay. Here, what you are supposed to do is you will kneel behind the child, keep the child close to your face, make a fist, keep it on the abdomen, and then thrust out. Then do abdominal thrust. You are actually thrusting on the epigastrium. Okay, so that the foreign body is expelled. The picture that is shown here is the typical universal sign of choking. You can see that the person is holding on to the throat. He won't be able to speak at all, because if there is foreign body sitting in the throat, you won't be able to speak at all. So whatever be the age, this will be the sign of choking. Okay. So whatever be the age above the infancy, the procedure that we have to do is the abdominal thrust. So that is how we expel a foreign body. Now moving on to the next patient. This is an 1-year-old child with a history of fever, cough for few days. Now the child has some respiratory distress, and the child also has an unusual sound. And mother also tells you that this baby has a breathing difficulty and has a hard sound which is coming from the throat. On examination, the child is lethargic with a respiratory rate of 1 minute. Actually, this is a video, but this is not moving. And I just exit and see. Okay. Okay, you heard the sound also. That this baby is having severe respiratory distress, and you are hearing a sound. What is this sound? This sound is known as stridor. You are hearing an inspiratory stridor. And also you also saw that this baby has retractions. The baby mainly has suprasternal and sternal retractions. I will try to play the video once more. We can look at the chest. You can see, look at this suprasternal area and the sternum, and you can see the retractions there also. Okay, so what is this baby having? The baby is having some, here also you can see whether the baby is having respiratory distress or failure. Here also the baby is having respiratory failure. Why? Because the saturations are less. Okay, so what is the difference when compared to the other child? You heard the history of the first child, or you had an acute onset. Here, the disease actually progressed over a few hours. Here also the patient is having inspiratory stridor, patient has severe retractions, cyanosis, hypoxia is there, because everything tells you that this is also respiratory failure. But unlike the previous case, this patient actually progressed over a few hours. Okay, so what could be the disease? Why is this baby having this problem? Can you think about the cause of this problem? Oh, very good, very good. Somebody has answered as Croup. This is the typical history of Croup. Usually, the baby will have some upper respiratory infection. The family members may also have upper respiratory infection. Then you would have the typical hoarseness of voice when the baby cries, or even if it's an older child, when he is speaking, there will be hoarseness of voice. Then we'll have a typical brassy cough, and this inspiratory stridor will be there when the disease progresses. Okay, so when the patient is having Croup, the treatment actually depends upon the severity of the in mild cases of the Croup, the child will have stridor only when the child is crying or coughing. There won't be any stridor at rest. As the obstruction progresses, you will be able to hear the stridor even at rest. And when it becomes severe, along with the stridor, which is the rectus, there will be marked tachypnea, marked retractions, and also hypoxia. So from this grading, it's very well clear that our child is actually having a severe. So how will you treat a child with Croup? The first thing is that this child needs to be given oxygen, right? This child is having hypoxia, so he needs to be given oxygen. But this oxygen should be given in the most unthreatening manner. That means you need to the first thing that you need to know is that you need to keep the baby comfortable. You don't have to make the baby lie down on a cot or anything. If the baby is remaining comfortable on the mother's shoulder or lap, it is better that the mother carries the child. Why? Because whenever you agitate the baby or whenever the baby starts crying, the distress actually increases. So you need to keep the baby in the mother's shoulder or lap only and don't make him cry unnecessarily. And whenever you're giving oxygen, also give it in the most unthreatening manner. You may say if it is only mild hypoxia, you may just keep the oxygen prongs little away from the nose. That is also okay if the oxygen saturation is maintained. And then you will have to give drugs to relieve this laryngeal edema. Actually, Croup is a infection, it's a viral infection, and due to the viral infection, it's otherwise known as acute laryngotracheobronchitis. So there will be some edema of your larynx, trachea, and bronchi. So that is why you have this, whenever there is laryngeal edema, you have this hoarseness of voice and stridor. So you give drugs in order to relieve the laryngeal edema. And so the drug that you give is steroids, and dexamethasone is the most preferred one. And how will you give the steroid? You need not put in an IV cannula and make the child cry. You can give it either as an IM injection or in cases of mild to moderate cases, you may even give it orally. A single dose 0.6 milligram per kg will be sufficient. And you can also give nebulization with adrenaline. When you give adrenaline actually produces vasoconstriction so that the edema decreases. Okay. Or you need to give a fairly higher dose of adrenaline, 0.5 ml per kg of adrenaline need to be given. So that for a 10 kg child, you need to take 5 ml of adrenaline, and the maximum amount is also 5 ml only. And if it is not a very severe case, you may even go for budesonide nebulization, and if dexamethasone is not being given, but it's always better that if you can give dexamethasone, it will be good because it's a longer acting steroids also, and its effect will last for 2 to 3 days with just a single dose. And moderate cases of Croup may be treated in the emergency room with dexamethasone and adrenaline nebulization. And it is always important that you discharge the patient only if there is no stridor for 4 hours after stopping adrenaline nebulization. Sometimes when you give adrenaline nebulization, the stridor disappears, and after a few hours it may come back. So always make sure that the baby child is not having distress or significant stridor before we discharge the patient from the emergency room. Okay, now we have gone to another case. This is a 3-year-old child who was brought for flu vaccination. And he was seen in the clinic by a doctor. Everything was okay. And he was given vaccination. Then what happened was that after 15 minutes from the observation room, the child was rushed back to the casualty with breathing difficulty. And on examination, the child is having a flushed appearance. You can see that there is a edema of the lips. Urticaria is there. This child is also having inspiratory stridor with a respiratory rate of 40 per minute. Tachycardia is there. Desaturation is also there. SP2 is only 88% in room air. Air entry is decreased bilaterally. Bilateral bronchi is there. And peripheries are cold with radial pulse beat. I would like you to tell me what are the systems or what are the organs involved in this patient, and what could be the cause for this disease. You can type in your answers. Okay, angioedema, anaphylaxis, skin, respiratory, very good, very good. Okay, so here you can see that there is involvement of multiple systems. You can see that there is actually involvement of the upper airways. 1 minute. My laptop is getting stuck again. I'm stopping sharing and then I share once again.
ഒരു ബ്ലാക്ക് ഔട്ട്
Actually, I think this is not the file. Can you see my screen now?
Yes, ma'am.
Okay, now it is moving. I think the screen becomes stuck when I'm going to look at the chats. Nisha, can you look at the chats?
No.
Okay. So what are the problems here? Patient is actually having upper airway obstruction as evidenced by the inspiratory stridor, decreased air entry and cyanosis. Patient also has lower airway obstruction because child is having bronchi is also there. Again, decreased air entry may be due to upper airway or lower airway obstruction. And there is shock also. Patient is having cold peripheries and weak pulses, and angioedema is also there. So whenever there is an acute problem which involves the upper airways, lower airways, then the cardiovascular system and skin, we always need to think about anaphylaxis. This is a diagnosis that you should never miss. Anaphylaxis, what is anaphylaxis? It is a life-threatening problem which is due to sudden release of histamine from the mast cells. When your body is exposed to an allergen and there are preformed IgE antibodies in your body, there will be a release of histamine from the mast cells, which will lead on to all these problems. So, if the patient is having skin manifestations along with the other system involvement, it will be easy for us to make a diagnosis of anaphylaxis. But there are few cases where the skin manifestation is not there. Sometimes you may just present with the respiratory distress and shock or GI manifestation without any skin manifestations. Then also we need to think about anaphylaxis whenever there is a constellation of findings. That is, different systems are involved. You need to think about anaphylaxis as your differential diagnosis. So how will you treat anaphylaxis? What is the drug that you give for anaphylaxis? So what is the drug that you give for anaphylaxis? You can write in the chat. Okay, adrenaline is the drug that you have to give for anaphylaxis. Even now, when we see cases of anaphylaxis in the emergency room, some of the cases are not receiving adrenaline. Adrenaline should be received for any child with anaphylaxis. So the first line treatment is always adrenaline, and it has to be given as intramuscular route. Okay. And the site of the injection is in the anterolateral thigh only. Don't give it in the gluteal region or in the deltoid or anything. In the anterolateral thigh, you will have to give the adrenaline as intramuscular injection. And it should not be given through the subcutaneous route in anaphylaxis. Why? Because in anaphylaxis, as we said earlier, the circulation is also compromised. So if you are giving through the subcutaneous route, the blood supply to the skin is less, so it will not be absorbed. So make sure that we are giving adrenaline only through the intramuscular route. What is the dose of adrenaline? Dose will be 0.01 ml per kg body weight. Suppose you don't know the weight of the child because this is an emergency. Anaphylaxis can occur at anywhere. Suppose you don't know the weight of the child, then also depending upon the age of the child, you will be able to give adrenaline. For children less than 6 years, the dose is 0.15 ml. 1 ml will be equal to 1 milligram. So 0.15 ml will be 0.15 milligram. And for 6 to 12 years, it is 0.3 milligram. And for about 12 years, it will be 0.5 milligram. So maximum is 0.5 milligram. It is the 1 in 1,000 solution. You don't have to dilute the adrenaline. Give it directly as intramuscular injection. The maximum dose, as I said, is 0.5 ml only. And after 5 to 15 minutes, if the patient's symptoms has not completely resolved, you can repeat the dose of adrenaline also. And the inhaled adrenaline or subcutaneous adrenaline should not be used in. It's actually not recommended to be used in anaphylaxis. This is the site of adrenaline injection. It is marked as X. You can see. So in the mid thigh, the anterolateral thigh, in the middle part of the thigh, you will give the intramuscular injection. Okay, along with the adrenaline, we also have to give other supportive management. This child is having respiratory distress, so and hypoxia. So the child has to be given and oxygen. Oxygen can be given through the non-rebreathing mask. We will see the non-rebreathing mask in the subsequent slides. Okay, and since the child is having shock also, patient should be started on IV fluid bolusins, 20 ml per kg of normal saline should be started. And if the trigger is still there, it has to be removed. This anaphylaxis may occur following injections, following food intake, then with the stings and following stings and all. Especially the bees will leave back their stinger. So it has to be removed also. And make sure that the child is in a position where the child is, the preferred position is lying down. You can see that the lying down position is the preferred. Or if you are in a place where you cannot lie down, you may even sit with the legs extended, and also the head can be tilted down also. And if it is a baby, if the baby can be kept either in the cot, or if the baby is kept in the mother's lap, baby should be held in such a way that the head is at in the level of the body only. It should not be held in such a way that the head is upper than the body. And even the sideways lying position can also be preferred, especially if there is associated vomiting also. And if the patient is having laryngeal edema, we can give adrenaline nebulization also. But at the same time, it has an IM adrenaline should always be given. Along with that, you may give adrenaline nebulization for significant laryngeal edema. And if the child is having wheezing, as in the case of our child, we can start him on salbutamol nebulization also. But the usual drugs that children receive when they are brought to the casualty or emergency room are antihistamines and steroids. What is the role of these drugs? Antihistamines are effective only for the cutaneous symptoms. They do not have any effect on the other manifestations, which are the life-threatening manifestations. So it's not that it should not be given, it may be given, but the first drug is always adrenaline. After giving adrenaline and stabilizing the patient with your oxygen, IV fluid, then only there is any role for antihistamine. And what the role of steroid? Steroid does not have any role in the immediate reaction. It does have a role. It prevents the late phase reaction. Sometimes the patient may have another bout of symptom after a few hours. If we give steroids, it will prevent the late phase reaction, but it is not effective for the immediate relief of symptoms. So some
asked to repeat the dose of adrenaline. Dose of adrenaline for different ages.
Dose of adrenaline is 0.01 ml per kg. If you don't know the weight, depending upon the age, you can decide the dose of adrenaline. For a child less than 6 years, it is 0.15 milligram. It's not per kg, 0.15 milligram. For 6 to 12 years, it is 0.3 milligram. Anyone above 12 years, it is 0.5 milligram. Okay. And if you calculate, if you know the weight, you can calculate 10 kg. Okay, so that is the dose of adrenaline. And it can be, if the symptoms are not subsiding by 5 to 15 minutes, you can repeat the dose of adrenaline. and make sure that you are giving it IM. That is the most important thing. Okay, so since these children can develop late phase reaction, any child with anaphylaxis should be observed in the hospital. Because sometimes if it is due to any oral drugs or food, there will be delayed absorption from the gut, which may be the cause for delayed reaction or the biphasic reaction itself. Because as we know, any immunological reaction can have two phases, immediate phase and late phase. And the chance of the patient getting late phase reaction increases if the initial symptoms were severe. If the initial symptoms were severe and required more doses of adrenaline, or if there was any delay in getting adrenaline at all, then there is an increased chance of our patient having late phase reaction. And always make sure that these children do receive steroids, and they have to be observed in the emergency room or in the wards for at least 24 hours before you discharge the patient from the hospital. And it's actually important. It's very important to prevent further episodes. It is as important as treating the acute episode. So always try to find out what is the allergen responsible for the anaphylaxis. From the history, we need to find out what is the allergen, and it has to be avoided. And always make sure that the patient has some adrenaline or EpiPen available, but it's very costly, and it is difficult to procure also in our area. So we can even go for this what we call indigenous adrenaline injectors, where you can fill in this adrenaline into a what we call insulin syringe or a insulin syringe there, so that the very small doses can be taken. But the thing is that insulin syringes usually have a subcutaneous needle with them. So make sure that you are using a syringe which does not have an attached needle. Well, that needle can be removed, and you have to connect a longer needle so that the injection can be given intramuscularly. So the patient can be given this pre-filled adrenaline syringe, and also you can write the instructions and keep it in a spectacle box. Here what you are seeing is actually the thing which is kept in a spectacle box. This was actually made by our own PG, and it was given to the patient. So that if you are giving this can be kept for 1 to 3 months. And after that, you can very well replace this. Okay. The only thing is that it has to be injected manually. It's not an auto injector, but you can teach the parents, or if it is an older child, this is a 10-year-old child, the child itself was taught how to inject. This child actually came with repeated episodes of anaphylaxis, and they were not affording the equipment. So we have to make this pen and give it to the patient. Okay, now we are moving on to the next patient. So this is an 8-year-old child with history of breathlessness and wheezing from today morning. The child on examination, the child is dyspneic. Child has prolonged respiration. Is able to speak only in words. He is also having tachypnea. You can see 30 per minute is higher. This respiratory rate is high or higher for a 8-year-old child. He is also having tachycardia, and respiratory is 92% in room air. And the chest, you can hear bilateral ronking, and there is history of prior episodes of wheezing, recurrent wheezing is there. So from the history, you know that this is likely to be an asthma, and the patient is coming to us with an asthma exacerbation. Okay, so what we want to assess when a patient is coming to us with an asthma exacerbation, so what you want to know is how severe is the exacerbation. Is the patient having respiratory distress or failure? Here, whether the patient is having respiratory distress or failure, we can assess by looking at the saturation. Here, the saturation is 92%. Then it's actually in the brink. If it is less than 92%, the patient will be considered as having hypoxia. So even less than 94% may be considered, but usually in asthma and airway diseases, less than 92 is the cutoff that we usually take. And so this is respiratory distress bar failure due to lower airway obstruction. So how to assess the severity of the asthma exacerbation? That is actually based on the work of breathing, and the sensorium changes. If the child is having only a mild exacerbation, the child will be having some tachypnea, and on examination there will be expiratory bronchi, but the child will not have any increase in the work of breathing. So there won't be any respiratory distress. If any child with asthma exacerbation is having increase in the work of breathing, that child has at least a moderate exacerbation. Okay. In the case of severe exacerbation, along with the respiratory distress, there may be sensorium changes. The child may be agitated. If it's a small child, child may be crying, or the main child may be drowsy. There will be hypoxia, that means there may be desaturation, there may be sweating, and air entry may be decreased. And another thing that we can consider to assess the severity of exacerbation in the case of asthma is the ability to speak. If it is a mild exacerbation, the child will be able to speak in sentences. In moderate exacerbations, the child will not be able to speak in sentences. They may be using phrases. But in severe exacerbation, the child may be speaking in words, or in very severe exacerbation or life-threatening exacerbations, the child will not be able to phonate at all, will not be able to speak at all. And if the patient is having severe respiratory distress, and at the same time there is no air entry to the airways, that means silent chest in a patient with respiratory distress, inability to phonate, diaphoresis, cyanosis, all those things tells us that this is a life-threatening asthma exacerbation. Okay, so where to treat and what are the medicines to be used will depend upon the exacerbation. Mild exacerbations may be treated at home, or maybe treatment may be started in the casualty and child may be sent home. Moderate exacerbation children should be kept in the emergency room, and we'll have to continue treatment. And any child with severe exacerbation needs ICU admission. So what the drug that you use? So the first drug that you have to use is actually oxygen should be given, because this child has a saturation of only 92%. So oxygen should be started. And the major drug or the major stay of treatment in the case of asthma exacerbation is the inhaled short-acting beta agonist. That is the major. Usually we use the salbutamol. Salbutamol can be used either through nebulization or an MTA spacer. Usually in the hospitals, we go for nebulizations. Here the child is having at least a moderate exacerbation. So you will have to give not a single dose of salbutamol. You will have to give repeated doses. You can give 3 doses back to back or 3 doses at 20 minutes interval and all. What is the dose of salbutamol? That also depends upon the age. In children less than 6 years, you will use 0.5 ml of salbutamol. 0.5 ml of salbutamol will contain 2.5 milligrams salbutamol. In children above 6 years, we can use 1 ml, that is 5 milligrams of salbutamol. There is no need for you to take milligram per kg or microgram per kg of salbutamol. Why don't we have to go for a milligram per kg? Whereas in pediatrics, for almost all drugs, we prefer to take it as milligram per kg, depending upon the patient's weight. Here, whatever be the, suppose you are giving the same dose, 1 ml salbutamol as nebulization for a child who is weighing 10 kg or who is weighing 30 kg, you are giving it for 2 children. Will the drug delivery to the lower airways be same in these children? Actually, it will not be. Why? Because actually that depends upon the drug delivery to the lower airways will depend upon the amount of air that you are breathing in. That means the tidal volume. The older child will always have a larger tidal volume, and hence more amount of air will reach the lower airways. So you need not go for a milligram per kg dose in the case of salbutamol. Okay, you can just take for a child less than 6 years, you will take 2.5 milligram, and for an older child, you will take 5 milligram. Anyway, if you are using a nebulizer, you will have to add normal saline, because the minimum volume of the nebulizing chamber, if you are using the usual jet nebulizer, the minimum volume will be 3 ml. 3 to 5 ml is the volume of the nebulizing chamber. So make sure that you add normal saline to make up the volume. between 3 to 5 ml. And if it is a respule, you need not add saline if the volume is sufficient. Respules usually come in 2.5 ml. So you may add 0.5 ml or so, or you may not even add if your nebulizing chamber is a small. And you will have to nebulize the patient with salbutamol. And another question is, which is better? As we said, we may even use MDI with spacer for exacerbation. For a mild and even moderate exacerbations, MDI with spacer is as good as or even better than the nebulization salbutamol. But the thing is that for a severe exacerbation, we have to go for nebulization. And always make sure that whenever you are nebulizing any patient with asthma, with respiratory distress, always make sure that you are nebulizing with oxygen. Okay. Now, why do you want to nebulize with when I am saying that you have to nebulize with oxygen, I'm not meaning that it has to be an oxygen-driven nebulization. Oxygen-driven nebulization is given only for a severe exacerbations. Even for a moderate exacerbation, make sure that the child is getting some form of oxygen while you are nebulizing. Why? What is the importance of that? Because here what happens is that usually in our lungs, whenever there is hypoxia, that means whenever there is a decrease in the air entry to a particular alveoli, there will be decrease in oxygen in that alveoli. That will be compensated by our body. There will be, it will be balanced by our body by the vasoconstriction of the supplying blood vessel. So that whenever there is a decrease in ventilation, the body will try to decrease the perfusion of that site also, of the lungs also, so that the ventilation and perfusion are matched. But whenever we are giving salbutamol nebulization, the salbutamol abolishes this hypoxia-induced vasoconstriction. So there will be an increase in blood flow to the alveoli, which are not getting ventilation. So that it actually exacerbates the ventilation perfusion mismatch, and the hypoxia can increase following salbutamol nebulization. So whenever we are nebulizing with salbutamol, any patient with some increase in the work of breathing, make sure that we are using oxygen also. Then in life-threatening exacerbation, we can go for oxygen-driven nebulization. There is no need for you to use the nebulizer in those cases. You can directly connect this oxygen to direct oxygen tubes can be directly connected to the flow meter. And by just the force of the airflow, you'll have to keep the airflow above 6 liters. The fumes will be produced just by the force of the airflow. Instead of the compressor, we are using direct. The oxygen source is used as the driving force for nebulization here. So this you need to use only for severe or life-threatening exacerbation. And always make sure that any child with moderate exacerbation is prescribed steroids. And steroids need to be given as only oral route if it is a moderate exacerbation and the child can take orally. If the child is vomiting, then we may have to give IV. Or if the patient is having severe or life-threatening exacerbations, then also we might have to go for parenteral steroids. But otherwise, only oral steroids is sufficient. And steroids, as I said, has to be prescribed for all children with moderate exacerbation. And in any child with even a mild exacerbation, if there is history of sudden severe exacerbations or any history of asthma-related death, then also you will have to prescribe oral steroids. Okay. And if the patient has any any risk for asthma-related death, they have to be kept in the hospital for at least 6 hours. These are some factors which are associated with asthma-related mortality. If the patient has any history of near-fatal asthma, especially any intubation for asthma, if the patient is not using inhaled corticosteroids, if the patient is prescribed inhaled corticosteroids but not using that, poor adherence, excessive use of short-acting beta agonist. That means using more than one canister of salbutamol per month. Then that means that patient is having uncontrolled symptoms and there is a chance of asthma related. So if the patient has any of these, then it is better that you observe the patient in the observation room, even if the patient is coming to you with a mild exacerbation. Okay. And other drugs for asthma, you can also give ipratropium nebulization. Here also, depending upon the age, if the child is more than 6 years, 250 microgram can be used, and if the baby is less than 6 years, 125 microgram can be used. And systemic steroids for as this we have actually described. Then if the patient is not having any improvement with tree nebulization, it's always better that you admit the child and continue to treat. And further, actually, emergency further management of severe exacerbation, we are not going to discuss. We are only going to discuss the emergency room management. Okay. So in the emergency room, we will give oxygen. We will start on short-acting beta agonists. We will give ipratropium nebulization also may be given, and make sure that you start steroids. Okay. Okay, that time skipping. Now we are going to further. Can you please mute?
Cracking sound.
Okay.
Madam, unmute ചെയ്തോളൂ. Bindusha madam,
Okay, okay.
unmute ചെയ്തു.
ഇപ്പൊ കേൾക്കാലോ ഇല്ലേ?
കേക്കാം.
പക്ഷെ എനിക്ക് വീണ്ടും ഒരു ഇഷ്യൂ വന്ന്. എനിക്ക് ഒരു സ്ക്രീൻ വന്നിരിക്കുന്നു. എന്റെ ഫയൽ ഇത് കാണാൻ പറ്റുന്നില്ല. ഓക്കെ, ശരി. Okay. Now we are going to the next patient. This is a 2-month-old child with history of breathing difficulty and cough, fever. Child has breathing difficulty for 1 day, not feeding at all, lethargic. Is drowsy, having severe respiratory distress, diagnosed. Chest is clear, respiratory rate is 66 per minute. Chest retractions are there. Saturation is very low, 80 only. Air entry is decreased bilaterally. Crepitations are there. Pulse rate is 180. Peripheries are warm with bounding pulses. What could be the cause? Can you see my slides now?
It's not visible.
I was trying to play a video. Can you see it now?
Not visible, ma'am.
Can you see my slides now?
No,
No?
ma'am.
No?
Slides are not visible.
I was trying to play a video, and it exited. Can you see it now?
Yes, ma'am.
Okay. Is the video playing now?
Yes.
Yes. Here you can see that the baby is having chest retractions. You can see that the baby is having severe chest retraction. The lower chest is actually moving in during inspiration. So what could it be? If the patient is having chest retractions, tachypnea, and not feeding at all, you will think of a diagnosis of pneumonia. Right. Here you can see that the baby is having a life-threatening disease. As we said, the baby is having severe hypoxia. Baby is drowsy. So the patient is having a life-threatening disease. And here, as described, the airway is clear. There is increase in work of breathing as evidenced by retractions, tachypnea, hypoxia, decreased air entry and crepitations. When you think about a parenchymal disease only, the respiratory failure due to parenchymal disease, you think about severe pneumonia. So how will you treat this child with severe pneumonia? What will be your first thing? First job will be to give oxygen. Here, this patient is having severe hypoxia with the saturation of only 80 per minute. If you don't address the child here, the patient can go in for cardiorespiratory arrest at any time. So you will have to bring up the oxygen saturation fast. For that, you use this non-rebreathing mask. Using this non-rebreathing mask, you can give a FiO2 of around 90 to 100%. So that this severe hypoxia can be treated. But since this child is very sick with severe hypoxia and all, the child may need intubation. Child may sometimes need non-invasive ventilation or even invasive ventilation. But arranging for an invasive ventilation and non-invasive ventilation will take some time. Even in a tertiary care hospital, you will have to shift the baby to the ICU and make sure that you have all the ventilated tubings. You will have to go for the procedure and all. But it will take time and the baby can crash at any time. So you won't be able to wait for the definitive management before you start oxygen. So to bring up oxygen saturation rapidly from 80% to somewhere around about 95%, we will have to use this or NRA. And while using a non-breathing mask, make sure that we are giving adequate flow. We need to keep an oxygen flow rate of 10 to 15 liters per minute. And always make sure that this bag is inflated. The bag should be inflated. If the bag is not inflated, you won't get higher FiO2. And this mask should be firmly applied or tightly applied to the face. And along with that, you will have to start on the definitive management. That is, antibiotic has to be started. And the usual antibiotic that we give for pneumonia will be ampicillin, or you may even give cefuroxime. WHO recommends ampicillin plus gentamicin as the first-line drug for severe pneumonia and ceftriaxone as the second-line drug for severe pneumonia. The second-line drug, ceftriaxone, also will be third-generation cephalosporin. It has to be started for any child with the risk of penicillin resistance. That means if the patient has not received the full dose of pneumococcal conjugate vaccine, or if the baby is having life-threatening infection like this child, where you have life-threatening disease, and if there is any recent antibiotic use. On these steroids, it's essential that you go for second-line management rather than going for the first-line management. And if the patient has in a risk for staphylococcal pneumonia, if it is a rapidly progressing pneumonia, or if the child has any abscess or pyoderma or X-ray shows pneumatosis, then you think about staphylococcal pneumonia. Then you have to start on anti-staphylococcal drugs also, like either cloxacillin, co-amoxiclavulanic acid, vancomycin, or even linezolid. In rare cases, it's a reserved drug, linezolid. So we will consider other drugs. Okay. So antibiotics has to be started, but the first thing that we need to do is the treatment of hypoxia. For severe hypoxia, we need to use non-rebreathing mask and give 90 to 100% FiO2 so that the saturation increases. Okay. Now coming to the last case, this is a 5-year-old child who was brought to the casualty. The child was actually sleeping on the floor with the mother, and he got up at the night with pain in the right forearm. He said that he has some pain in the right forearm. Then he went back to sleep. He got up around half an hour after this incident with abdominal pain and he vomited. Then he had some difficulty. Then the mother gave her some tea and he had some difficulty in swallowing the tea. Became lethargic, was not able to walk at all. He had to be carried to the hospital. Now, at the hospital, there is some difficulty in breathing also. On examination, the respiratory rate is 10 per minute. There is labored breathing. There are some secretions in the throat. He has an SpO2 of 95% and the child is on nasal now. Pulse volume is 100 per minute and there is good volume. So what is the patient's problem? You can type in
Snake bite, neurotoxic snake bite they have written.
Okay, very good. You are thinking about snake bite. So this is just what I have described is the typical progression of a neurotoxic environment. The thing is that you may not always get the history of a bite as such. Here the bite, there was a history of some pain, but nobody understood that this is a snake bite. What I have actually described is the history of one of our patients only. It's not a fictitious patient, it's just the patient came with the same history. So over the few hours, the disease actually, the neurotoxicity or the paralysis progressed. Here you can see that the patient is having bradypnea. The respiratory rate is only 10 per minute and the baby is having labored breathing. At the same time, the saturation is maintained. Even the patient is on nasal bronch, but the saturation is maintained. Here, the major problem will be ventilatory failure. Okay, why? Because when the patient is not breathing, so in a patient who is not breathing or who has bradypnea, hello? Okay. If a patient is not breathing and is having bradypnea, giving oxygen alone is not sufficient. This patient has to be mechanically ventilated. So if you don't have any facility for intubation, we can go for a bag and mask ventilation. Bag and mask ventilation alone will actually save the life of a child. And if we do have expertise for intubation, it's very well that you go for intubation. And if you don't have expertise for intubation, we can use this instrument. This is a laryngeal mask airway. You don't require any expertise or anything for inserting it, this laryngeal mask in airway. It can just be inserted just like the oropharyngeal airway. You can see that it is just inserted into the mouth and it reaches the upper part of your larynx. It acts as a mask which sits over your laryngeal opening, and we can ventilate using this laryngeal mask airway during transportation. It may be difficult for us to transport a child by doing a bag and mask ventilation. Mask ventilation will be difficult for us to transport, but if you are able to put in a laryngeal mask airway, the child can be transported very well. And make sure that we continue ventilation. And earlier, a few years back, we used to get neurotoxic inhalation without being intubated or without being even without bag and mask ventilation. I'm very happy that nowadays, even from the periphery, we are getting children who are intubated and given bag ventilation, so that just intubating and giving bag ventilation will save these children. We need to give anti-snake venom also, but if you don't have, even if you don't have the anti-snake venom, it can be given from the next hospital. But the delaying this ventilation may be deleterious to the neurological outcome. So make sure that you need to ventilate this child and also give definitive management, that is anti-snake venom and may have to refer to the higher center if it is not available in your place. So what have we discussed in this class? We have discussed that if there is any abnormality in the initial assessment, we need to think that the child is having a life-threatening disease and have to take immediate action and may have to go for resuscitation if required. And if there is an obstructed upper airway, we'll have to suspect foreign body if the history is suggestive, or if it is an acute onset, then go for foreign body removal by the different techniques. If it is Croup, you can give IM dexamethasone or nebulized adrenaline. In case of anaphylaxis, IM adrenaline is the drug of choice. And if the patient is not breathing or bradypneic, start bag and mask ventilation, secure airway with ET2 and LMA. And in the case of lower chest airway obstruction, if asthma, then salbutamol nebulization and steroids are the drugs to be used. Oxygen-driven nebulization can be used in severe exacerbations. In parenchymal diseases, give oxygen. If severe hypoxia, use NRM as the initial oxygen delivery device. Start antibiotic. Okay, thank you. Thank you
Thank you,
for the.
And few queries in the chat.
Yes, we will discuss the queries.
They have asked regarding the repeating the dose of adrenaline. How many times they
Okay.
can?
If there is no response within 5 minutes to 15 minutes, we can repeat adrenaline. We can repeat up to 3 doses. Usually that will be sufficient, but if there is what you call feature shock is not getting corrected even after 3 doses, we may go for IV infusion. But that is not the drug of choice. The drug of choice is always IM adrenaline. The first 3 doses should be given as IM only.
Regarding home nebulization.
Home nebulization in asthma. In asthma, it is actually better to avoid home nebulization. Why? Because as we said, if the patient is having significant respiratory distress, the child actually needs oxygen along with the home nebulization. So what will happen is if you are prescribing home nebulization to the parents, what will happen is they will think that that alone is sufficient. And so even if the patient is continuing to have symptoms or the respiratory distress is worsening, they may continue with the home nebulization and they may not recognize that the disease is progressing. So, and also as we said earlier, MD with spacer is as good as using nebulization. So we can prescribe MD with spacer, and if the patient is not improving with the MD with spacer, they will have to come to the hospital. And another problem with home nebulization is that it can actually sometimes it may lead on to infections also if the nebulizing chamber is not cleaned properly. So for asthma, we don't. It's better to avoid home nebulization and give only salbutamol MDA spacer for SOS use at home.
It's regarding Montelukast for asthma.
Montelukast is actually, it is actually nowadays it is not a good drug which is recommended for asthma. Gina actually says that there is a box warning and we have better drugs. Inhaled corticosteroids are the drugs which has to be used for asthma. Montelukast is associated with a lot of neurological problems. The children may have night terrors and all. And in adults, there is an increased chance of suicidal tendency. So neuropsychiatric problems are associated with Montelukast. So it is a drug which is better avoided in asthma.
Any other queries?
Role of magnesium sulfate nebulization. Okay, magnesium sulfate can be used either as parenteral magnesium. Actually, we did not discuss up to that level. We actually discussed only the emergency room management. If the patient is not improving with the salbutamol nebulization and ipratropium steroids, then the next drug that we usually use in emergency rooms and ICU is the IV magnesium sulfate. And just like IV magnesium sulfate, magnesium sulfate nebulization can also be given. In the earlier editions of GINA, they used to recommend this magnesium sulfate nebulization, but nowadays it's not there in the guidelines, but it may be given if the in a patient with exacerbation, which is not responding to the conventional management. What you usually do is we will take 0.5 ml of magnesium sulfate, add 0.5 ml of salbutamol solution, and add 4 ml of distilled water. There, instead of saline, you add water So that will give you an isotonic solution of magnesium sulfate. It may be given. There are some studies which shows that there could be improvement with magnesium sulfate nebulization.
They have asked to repeat the salbutamol dose for asthma.
Salbutamol dose for asthma nebulization. Salbutamol dose is actually very easy for you to remember. For children less than 6 years, it is 0.5 ml of nebulizing solution. 0.5 ml of nebulizing solution will contain 2.5 milligram of salbutamol. Okay. For an older child, above 6 years, you will take 1 ml of salbutamol nebulizing solution, which contains 5 milligram. Add saline so that you will make it up to at least 3 to 5 ml. You can add 3 ml to this so that it will be 3.5 or 4 ml. That is okay because most of the nebulizing chambers has a volume of around 3 to 5 ml. And how many times that you have to give, that depends upon the severity of the exacerbation. If it's a mild exacerbation, if you nebulize once, the patient may become better, you don't have to repeat. But if it is a moderate exacerbation, we usually nebulize 3 times and reassess. If the patient is improving, then you will space up the nebulization. So from half an hour interval, you make it 1 hour interval, 2 hour interval. And like that, you space out the nebulization, change to MDI and send them home. Or if it's a severe exacerbation, you may even go for a continuous nebulization. Okay.
Regarding theophylline for asthma exacerbation.
Theophylline are actually better avoided in asthma. Yeah, nowadays, the guidelines do not recommend the use of aminophylline. But in the case of very severe exacerbations, which do not actually respond, some centers do give aminophylline, but Gina and all, they actually recommend against using the theophylline. Okay.
And regarding the ability of transportation using LMA alone.
Transportation?
Using antigen mask airway.
Okay, once we are able to, LMA, different sizes of LMAs are available from 0 to 5. Different sizes are available. And on the LMA, it's actually written what is the, it's actually weight based, depending upon the weight. It's written what is the weight for the child for which that particular LMA has to be used. Once you put in that LMA and inflate the mask, it will remain there. It won't just come out. We can tape it to the lips, just like you fix the endotracheal tube, and connect the ambu back to that LMA and back, or it may even be connected to a ventilator for transport. That is also okay because the end of the LMA, it's actually just like the ET tube only. So it can be connected to the ventilator also for a short time. Once you have anyone who has expertise in intubation, you go for invasive, for intubation and invasive ventilation. Till then, you can continue LMA.
Regarding deflazacort can be used in for steroids.
Okay, deflazacort can also be used. It's just another steroid. It has a lesser, what do you call, hypothalamic suppression and all, so it may be used. But the advantage of using the deflazacort comes only in cases where you give steroids for a longer time. In case of asthma, we actually don't plan to give steroids for a longer time. We give only 3 to 5 days, maximum 7 days. We don't give more than that. So prednisolone is as good as any other drug.
And if the bacteria infection superimposed while on steroids,
which one?
Steroids and supervening bacteria infections, madam. They have asked whether we should discontinue steroids.
Okay. What if the patient on steroid puffs get bacterial upper respiratory infection? Should we temporarily stop steroids? That actually depends upon the indication. If it is an asthma, then actually you need not discontinue the steroids, because if you are discontinuing the steroids means inhaled corticosteroids, steroid puffs, discontinuing the inhaled corticosteroids while the patient has an upper respiratory infection will actually lead on to an exacerbation. And what is the bacterial upper respiratory infection? What do you mean by bacterial? Most of the upper respiratory infections are produced by viral. The bacterial upper respiratory infection may be rhinosinusitis. Sinusitis may be the otitis media and tonsillitis. These diseases do not warrant a discontinuation of inhaled corticosteroid, which we were using for asthma. That can be continued, but you need to treat the infection depending upon what is the infection. Why only salbutamol? Actually, somebody has asked why only salbutamol inhalation should not be given. I actually did not understand. Actually, is it regarding that the oxygen has to be given along with salbutamol? It must be. That I think I have explained that. Because in cases of moderate exacerbations, at least moderate exacerbation, where there is an increase in the work of breathing, oxygen has to be given along with nebulization. It need not be oxygen-driven nebulization. You just need to just keep the what you call oxygen, nasal prongs oxygen or something while you are nebulizing. Okay. Can we add Pulmicort nebulization to salbutamol for exacerbation? Pulmicort is inhaled corticosteroids, right? Inhaled corticosteroids may be added, but actually it may not have much effect. During the exacerbation, if it is a moderate exacerbation, that child requires systemic steroids. Okay. When you're giving inhaled corticosteroids, you're giving it in microgram doses, right? One puff will be 100 microgram, 200 microgram. When you're giving systemic steroids, we are giving it milligram doses. So during an exacerbation, the child, if it is a moderate exacerbation, child will require systemic steroids. Okay. But if it is started early, that means when you're going for the home management, when the patient develops symptoms, along with the salbutamol MDA, when we ask the patient to take the salbutamol MDA, you can give budesonide or inhaled corticosteroid MDA along with that, depending upon the frequency of symptoms. Okay. Actually, inhaled corticosteroids are the controller drug, but sometimes it may be given when the patient has symptoms along with the salbutamol. You can give, you can increase the dose of inhaled corticosteroids also. That is known as anti-inflammatory reliever therapy, where you give both rotating beta agonists and steroids. Another question. What is the indication for adding hypertrophy nebulization in casualty setting? Okay, I'll take that question. If the patient is not improving with your salbutamol nebulization, if the patient is still having respiratory distress after your salbutamol nebulization, you can combine ipratropium along with salbutamol. Okay. So ipratropium acts through another receptor. It is a muscarinic antagonist. So it will act short-acting muscarinic antagonist. So it will actually add on to the effect of the beta agonist. And there is another thought that actually muscarinic receptors are the more in the larger airway. So it will adding ipratropium will produce what you call dilatation of the larger airway. So there is salbutamol, whatever salbutamol that you're going to give after that or with that can reach more distally. That is another thought. Okay, can you brief on management of bronchiolitis presenting as respiratory distress? Actually, that is something that actually I did not touch upon in this presentation. Okay, so bronchiolitis. Actually, bronchiolitis is a very common respiratory infection. Usually comes as seasons. during the rainy season or in the winter season, you will see a lot of children coming to you with bronchiolitis. The usual history will be like the baby may be having an upper respiratory infection, and the family members may also have the URA. Then the baby will start coughing, will develop respiratory distress and wheezing. That is the usual presentation. And when you are seeing the baby may be having severe tachypnea, there may be some retractions, and there will be bilateral bronchi. In the X-ray, you will see hyperinflation. That is the typical history. How to manage bronchiolitis will also depend upon the severity of the bronchiolitis. In milder cases of bronchiolitis, you need to go for only supportive management. That means in bronchiolitis, the child may have even the nasal block. The nasal block may be the major thing that leads on to the discomfort to the patient. Make sure that the nose is open. You can instill the saline nasal drops. And in some patients with respiratory distress, you may go for the other drugs which may be effective in bronchiolitis. The major drug that is given for bronchiolitis is oxygen alone, because bronchiolitis as such is a self-limited condition. The child will have symptoms for a few days. In majority of the cases, they will subside. But in some cases, some patients may progress to develop severe bronchiolitis or may develop secondary pneumonia too. But majority of the children, it will settle by a few days. So what you need to do is provide comfort to the respiratory system. So what you do is you give heated, humidified oxygen. That is the only thing which is needed for majority of the patient. But if the patient is not responding to that alone and has severe respiratory distress, we may resort to 3% saline nebulization. Hypertonic saline nebulization may be given, which decreases, which has some role in decreasing the airway edema, and it may help in liquefying the secretions. One of the factors which will lead on to the discomfort is the what do you call the respiratory distress due to the secretions assay. So that can be actually liquefied by using this hypertonic saline. Then nebulized adrenaline is also another drug that you use. I think it has to be, it's a topic which has to be discussed in detail. In brief, I think this will be sufficient. If salbutamol and salbutamol ipratropium are available, which one is preferred for acute as nebulization and referral antibiotic? Okay. Majority of the cases of asthma exacerbation, mild and moderate exacerbation, requires only salbutamol. Okay, only if the patient is not responding to your salbutamol alone, you need to go for the ipratropium, or if the patient is coming to you with severe exacerbation, you may use ipratropium earlier. Any role for antibiotics in bronchiolitis? No role at all. I think I didn't get all the questions, Nisha. ഇനി വേറെ ഏതെങ്കിലും ഡിസ്കസ് ചെയ്യണോ? In ARI admission at hospital, can injection ampicillin long be given, should always be combined. But that actually depends. In the case of severe pneumonia, WHO suggests to give ampicillin with gentamicin. The thing is that in cases of gentamicin is an antibiotic which is effective against gram-negative organism, and it may also have some synergistic effect against some gram-positive organisms. So that is why WHO suggests like that. But in say, you need not always go for gentamicin also. In an older child, you can give ampicillin alone. Okay. But if it is a younger child or has other issues like immunodeficiency and all, it is better to go for a combination. Okay. എല്ലാം കഴിഞ്ഞില്ലേ നിഷ?
This 1-year-old child with family history of allergy. Auscultation, the child is having occasional wheeze.
ഞാൻ കണ്ടില്ലത്.
Asked question, ma'am. And so they have asked short course of montelukast.
ഇടയ്ക്ക് എൻ്റെ കണക്ഷൻ കട്ടായി.
Ma'am.
നിഷ എൻ്റെ കണക്ഷൻ ഇടയ്ക്ക് ഒന്ന് കട്ടായി പോയി. ഞാൻ
Okay.
കേട്ടില്ല എന്താ ചോദിച്ചേന്ന്.
This is a 3-year-old child with family history of allergy. Now the child is presenting with fever, nasal obstruction, moist cough. There is no tachypnea, no work of breathing, and the child has occasional wheeze on auscultation. So they have asked any other possibility other than viral infection to wheeze.
There is family history of asthma also.
Yes, family history of allergy.
Family history of allergy is also there. Usually a 3-year-old child coming to you with what you call respiratory infection and wheeze is usually having a viral induced wheezing, or what we earlier called as viral wheeze associated lower respiratory infection, or a viral induced wheezing. This child is having wheezing due to the viral infection. The management actually depends depending upon the associated symptoms. Suppose the child is having wheezing in between also. When the patient is having viral infection, the child may wheeze. And in between, if the child is all right, the child is not having any wheezing at all, and the child is not having any other allergic diseases, we may think that this is already viral induced wheezing, and we will give drugs whenever the patient comes to you with the wheezing only. Suppose the child is having wheezing in between, or the wheezing is prolonged, severe wheezing and all, it is better to manage as asthma.
And regarding short-term use of montelukast.
Actually, montelukast is
service.
not recommended for an acute exacerbation of asthma.
Yes, ma'am. I think the questions are over.
Okay, thank you, Nisha.
So, dear friends and seniors, all the residents, come to the end of this discussion on respiratory emergency in children. So, Bindusha madam have given a clear and presentation of the common pediatric emergencies that is in the casualty and how to tackle them, how to assist the child. And it was very interesting with all the case scenarios and videos. So I should profusely thank my tips.
Thank you, Nisha. I also would like to thank everyone who has participated in the discussion. Actually, I was not able to read the chats well because my computer was getting stuck. But I would like to thank all the house surgeons who answered the questions and participated. Thank you.
All the residents and the my pediatric friends who have joined the sessions.
Yes.
Thank you.
Thank you.
Good night. We shall stop.